were we unfair to our patients who died from COVID? It's not been so long we came out from this COVID pandemic. We experienced the lockdown. There was so much panic. People were really frightened. And yes, we lost a lot of people. So many people died. So many doctors died. So many members of the public died from COVID. There are findings now, studies that are beginning to confirm what many of us felt from the beginning. There are findings that are now saying people who died from COVID may not have died from COVID, which means they had COVID, but they may not have died from COVID. They may have died, rather, from what we call bacterial superinfection. There's a study, this one that is just behind me, that is beginning to show that up to 50% of people that died from COVID likely died from bacterial superinfection. And what does bacterial superinfection mean? I'll explain it in simple terms. When we have a viral infection like a flu, what that viral infection does is it causes inflammation of our airway, the lining of our airway, the nose, the larynx, the trachea, the bronchi, the bronchioles. It causes that the lining of those airway pathways or channels to be inflamed. And what happens in inflammation is that there's swelling. That's continuity. If you look at the skin, there's supposed to be continuity, epithelial continuity to protect, to create that separation. It's like looking at a wall. The wall separates the outside of your house from the inside of your house. If there's a hole on that wall, then there's a channel through which maybe a rat or a lizard or something, crickets or insects can crawl in from outside into your house. So when you have a viral infection and inflammation of your airway, there's a breach in the integrity of that epithelial lining in your airway, such that bacteria that would normally be found on several parts of your airway, which we call the normal flora, or being currently popularized as the microbiome of the body, those normal flora bacteria, will now find their way from within the airway through that breached or compromised mucosal epithelial membrane, and then it gets into deeper tissues and then trigger more inflammation, sepsis, and what we call respiratory distress, acute respiratory distress, and then obviously swelling, fluid, lots of fluid in the lungs, reduced oxygen transfer, and the person can die. The person could die. These were my thinking right from the start of COVID, when people said they're dying. Some of us, mentioned it then. There were no research findings then to corroborate or support that yes, we should be giving antibiotics to severely unwell, COVID patients. There were lots of antiviral, lots of use of steroid, prednisolone, methylprednisolone, and a lot of things, lying patients, in prone decubitus, lying them facing down to increase lung oxygen transfer through the alveoli at the back of the lungs. A lot of things we did in good judgment and in good faith. But something we ignored was empirical antibiotic treatment for a lot of those patients. And I say yes, we ignored it. It's something that should have been popularized during the COVID pandemic, the use of empirical antibiotics for patients who were diagnosed with COVID, especially those who ended up being, having severe lung infections, being transferred to ICU. The use of antibiotics should have been popularized. Unfortunately, it wasn't, and we lost a lot of those patients. Now, some of us, who were really junior in the career, made such suggestions, but maybe it wasn't evidence-based then, so such suggestions or opinions were not implemented. And it's something really that happens a lot in medicine. A lot of doctors are scared, to practice non-evidence-based medicine, which means things that you might think out from your mind as a scientist, because as a doctor, you're a scientist. So there are things that when you see a problem, you should be able to think and say, oh, what do I think is causing this? What do I think should be the solution? If there's no evidence yet, which means if a lot of data has not yet been collected, like COVID was new, we have been bombarded by the pandemic. We didn't have enough data to support a lot of things that we were doing at that point. But people were having thought processes, people were having suggestions. A lot of people were having suggestions, but because there was an absence of data, and especially if you're junior and you have brilliant suggestions, your suggestions may actually not carry weight because you're not an authority, you know what I mean? You're probably a junior doctor, an intern, an F1, an F2. You might come up with a very brilliant suggestion, but the likelihood that suggestion will be taken serious is low because you're not one of the bosses, you know what I mean? There is tendency, obviously, for us to respect opinions when they come from higher up, come from the big boys, you know, the consultants, the professors, and not really take opinions serious when they come from much, more junior doctors or junior scientists. So it's something that unfortunately happened during COVID and unfortunately continues to happen. It's sad. Now it's coming out and a lot of people are making it look as if it's a highfalutin knowledge. No, many of us spoke about it during the pandemic. Many of us spoke about the sense behind empirical antibiotics. Understanding what we call pathophysiology, which is one thing that every doctor does. When you understand the pathophysiology of a disease process, then even the absence of data, enough data to support that thinking, you can do what we call an empirical, which means based on your thought process and your understanding of what's likely going on, you should be able to try some things, empirical antibiotics. So that's what I think we should have done. Empirical antibiotic treatment for a lot of our patients who are getting worse. I strongly believe so many people who died, wouldn't have died if we had given them broad spectrum antibiotics. It is sad to say, but that's what we are beginning to see. A lot of data, that are being rolled out are now beginning to support that assertion. Another thing I'll just mention is, as doctors, I remember at the start of COVID, the face mask thing. When COVID, we're still getting news of COVID. It was still in China, spreading out from China and coming more towards the West. I remember, being in a group, with some of my colleagues, and I was like, we should start using face masks. And we were like, WHO, there's no evidence yet to support that, we should be using face masks. And I was just saying that we are scientists. Let's not forget that as doctors, we are scientists. Even without data or evidence to support that, we should be using face masks. Here we have a new virus that is spreading. We're getting news of how fatal and how virulent, it is, and how highly contagious this virus is. We're getting, and then WHO at that point was giving us information about this particulate size of the virus, that you need to be in very close proximity to someone who has COVID to contract it. But I was like, this is what WHO is saying. But the information, the practicality on ground is that people are contracting this so fast and people are dying. People are becoming very sick, very unwell. So based on practical grounds, without really completely pushing what WHO was saying, aside, we should have been using face masks much earlier. And then a lot of people were like, hey, there's no evidence. And a few weeks after that discussion, I remember everyone was on face mask because the mortality, the virus got to the UK, mortality was like skyrocketing, and yes, people were really on face mask. So why am I saying this? I'm not saying it to make it look as if I'm very smart. No, I'm saying it because as doctors, we're scientists, and when we don't have enough data, we should be able to do what we call empirical practice, which is based on what we can see. We should be able to institute certain measures, certain steps to help prevent certain diseases. And even in the absence of data, based on our understanding of pathology and pathophysiology, how diseases evolve, we should be able to do certain things. So we should have given empirical antibiotics to a lot of our COVID patients. Now, one reason why there was not a high mortality, from COVID in Africa, despite the fact that Africa didn't really have access to vaccines and access to a lot of high-tech, medicine, is because in Africa it's commonplace, even though it's a bad thing, but it's commonplace for people to self-medicate with antibiotics when they have chest problems. And I believe, a lot of people self-medicated during COVID, whether it was confirmed they had COVID or not, they had chest flu-like symptoms, got over-the-counter antibiotics and took it, and that may have been, the saving grace for some of those people. The fact they took over-the-counter antibiotics, even though we advise against self-medication. But I'm beginning to think that self-medicating with antibiotics may have been responsible for the low mortality from COVID in Africa. That's what I'm beginning to think. I've been thinking that, I'm beginning to strongly believe that. I hope we can get data from African countries to corroborate this thinking.